The wire is broken and touched. I learned this from this director Chen. That he stitches. He has a thread about a centimeter or two. After leaving a thread, I'll sew another proline thread. After tying a knot, clip the thread tightly with a needle holder. Then use this thread sewn at the back to tie a knot with the needle holder. It will take a while to push the knot stick in, but it will definitely take some time to rematch. The problem is that after the tracheal anastomosis, how long is radiotherapy generally safer? The radiotherapy after anastomosis depends on: first, take a look at the bronchoscope. Bronchial mucosa heals very well if it is continuous. Radiotherapy is ready. But let me add one more thing here. I'll add that it's about the wire being broken. I think you can sew again if the pull thread is broken. Also, after finding that it is done, this line seems to be extra somewhere. What should I do if it is loose? It's loose, of course don't do it again. When it's loose, you can go around and sew it again. 2 threads knotted. This is the way you sew on the side. Just tie the 2 more knots. Just put a thin thread inside the thread and pull it out. It's like a thread. Then another stitch next to it. 2 knots. There's also the question of how to place the pedicled muscle flap near the anastomosis. How? This is going to be a big opening. Why open surgery? Because the latissimus dorsi is long, but the latissimus dorsi can be made into what's called a thin muscle flap. And of course, serratus anterior. Be sure to speak. He wants to cover it. Of course, some people use intercostal muscles. The intercostal arteries and veins act as this branch office. The intercostal muscle will make a small strip. In fact, the intercostal muscles can. I have also seen this method. Just shave it off against the ribs on either side. Yes. The vessel cannot be ruptured or it would be meaningless. But I use my latissimus dorsi the most, because a lot of esophageal and bronchial leaks or something. Patient delivered. I use a lot of them. I use the latissimus dorsi serratus as well. The latissimus dorsi solves a lot of problems, so I try to keep the latissimus dorsi. Okay, regarding sleeve resection, Director Chen and Mr. Chanda, do you have anything to summarize and add? Sleeve resection is a complicated procedure. You need a certain foundation, but you can do it. But I think according to the tumor principle, if you can't sew well, after you do the premise first, you feel that the sewing is not good, you have to open your chest without hesitation. Don't care about this incision. Safety is paramount. Nothing is more important than patient safety. Besides, I don't think it's anything. Because the course will be faster earlier, including how to hook some of this hook line. I think then everyone has a chance. I still borrow the platform of Director Wang to help us make an advertisement. Some of them are willing to communicate or ask questions. It will be better for us to teach on site. We have an issue in November that will be more delicate. Some emulator platforms with gun mirrors. I hope you will give more valuable opinions. Okay, looking forward to it very much. Take this precious opportunity. Director Chen Jishuan and Teacher Chenda. I have learned a lot of skills from the 2 teachers at home. I'm the trigger. Take out this lung segment surgery and let the 2 teachers comment and guide you. You're welcome. Director Wang Ming did a good job of lung segmentation. Thank you very much. I'll start sharing. Can you see my screen? Can see. This is a subsegmental resection of zone +2, A plus D, in the upper left lung. Then after the break, pure oxygen will drum the lungs. Since this person has a barrel chest, so I'm a little dissatisfied with the pull. Wang Ming, wait a minute. I think you used the method called no waiting. Right. Have you adopted a no-weight approach? If you break an artery, you bulge your lungs. Yes, I want to tell you that this is learned from director Chen Qixuan. Here's how we do it. Later, I summarized and wrote the word no weighting. But I think the method is still very practical. You see him break this artery and then bulge his lung again. This interface comes out. This wiring is all out. It doesn't need to be very stressful at this time. The lungs bulge easily. And then we can do other veins while we wait. In about 7 or 8 minutes, the boundary is already revealed. It's along this fault plane. Here is the energy instrument door opening method. Sometimes if the incision is larger, or a better angle, we'll also use the bayonet method. I'm going to talk about the second video later, which uses the bayonet door opening method. Open with a closure. Each has its advantages and disadvantages. Break this V plus tube. Lift the distal end after breaking the internal vein. Just along this interseptal vein and the interseptal plane. This expansion and collapse plane continues to cut. I think Director Wang did a good job of opening the door just now. I don't think a lot of doctors like that. Cut off this lung parenchyma for fear of air leakage. I don't think you should worry about it because the door doesn't open. The deep structure inside cannot be displayed. So don't worry about air leaks in this place. If you sew 2 stitches, there will be no air leakage. Yes, just use that absorbable thread to sew 2 stitches intermittently on the surface of the intravenous vein. Just sew the lung parenchyma and the air leak here will be done. Next, in this Aone plus Tuk branch, it is relatively thin. If you pull it like this, the root will turn a little red. So we have to be very careful here. Don't damage the root. This group 12 lymph node is removed. It exposes the bone plus 2, A plus B, below. You can also see here the intersectional plane. It's this intersectional plane, essentially, of the lung inflated infinite plane. Then this place is also open. Under the seam before the single hole in your place. Stapler is still not easy to use with a closure device, so I burned it with an energy device. After boiling, you can see the target bronchus below. Go a little bit to the target segment and hook it up a little bit. Show this B plus 2A plus B. It's close to the bronchi. You look at this target, the boundary of the bronchus. Below the bronchus is the severed intravenous vein. There is basically a severed intravenous vein between segments. It's actually very interesting. As thick as the artery is, so is the bronchus. This artery is thin, so are the bronchi. Yes, it's accompanying. Then double joint separator forceps are used along the vein and vein surface. Patiently separate between veins and target bronchi to avoid puncturing the vein. I like to use a vasectomy after separation. Ligate with line 7 or line 10. The advantage of ligation is that it does not affect the bronchi to be preserved. Just sometimes this person's bronchi are very soft. Then after you lift it up and clamp it with a closure device. If you don't bulge your lungs, may cause bronchial stenosis in adjacent segments. Of course, this is a double knot. A ligation is actually enough. Because it has cartilage rings, it generally will not slip off. Then you won't loosen if you tie more than 4 or 5 knots. Now continue dissection along this vein. The point now is to loosen the distal end of the bronchus. It's Duan Man looking up. Follow Director Chan's steps. How to identify intrasegmental and intersegmental veins. After lifting this distal bronchial, towards the distal end of the bronchus is the intrasegmental vein. Away from it is the interterminal vein. Like now I suspect to see an intrasegmental vein. I'm not so sure. Flip to the front again and take a look. Lift the distal bronchi as well. It's definitely towards the distal end of the bronchus. We thought it was a severed internal vein. Wang Ming, what's the problem? is the difference between the elderly and the young. I'm having a hard time remembering these blood vessels and veins. I can only use this method. But you young people still have to figure out all the veins. How? That's even better. I think if you do a dissection, it is still recommended to do treat reconstruction. You actually remember all these blood vessels in your head, and you can figure out which vessels to break. It is very clear which blood vessels should not be broken. It's hard to remember at our age, so that's the only way I can do it. Which blood vessel went into the target? Then I'll dispose of that blood vessel, and it worked. Just when you can't figure it out, especially if there is an intersectional plane, it is easy. Make sure if this is a severed internal vein to keep. And then the severed blood vessel. After the bronchi are treated, just crop it along the fault plane. We can bayonet it open in layers here. This is just to save some money. I used an ultrasonic knife to boil it. Then a few stitches were sutured intermittently. I was in a hurry. If there is no intermittent suture, lung bulging doesn't necessarily mean air leaks. That's how this energy device PK breaks the door. Then a relatively stretched intersectional plane is obtained. The lungs are bulging and there is no air leak. The pressure is 25. Director Chen, tell me, you said it's all over. I'm done with this. Director Chen said, time is running out. It doesn't matter if there is time. It doesn't matter if there is time. Let me comment on this. Surgery like this should be a standard 1+2 AB resection. Sometimes we also break C. This person's C is farther apart. A lot of people are doing it now. Well, I think there are two ways of doing it. One is called intentional excision. And then there's the idea of compromise excision. Compromising patients often have poorer lung function, if intentional, mostly because I thought the lymph didn't actually metastasize. And it's deeper. We perform resection on this patient if the location is very marginal. We are completely adaptable to technology. Let's not complicate simple things. Compromise is different. Compromise why lung function is poorer. This patient is supposed to have a lobectomy. What if he doesn't have such lung function? The lymphatic dissection requirements of this patient are relatively high. Young people, I think we need to consider amputation first. Make sure every blood vessel is clear. I think this will be helpful throughout my career. I like Wang Ming's surgery. I would make it a little easier. I went along the trachea, and after I broke, I went along this. As long as the cutting edge is enough, this section will be cut off. Very good surgery. Chen Dana, look at this surgery. You bring up your ideas. I'll just say a little. It's actually a segmental or some of this lobectomy. Places where interleaf fissures are not fully developed. We sometimes have electric knives or ultrasonic knives. Then I think there are so many ways. The best way is to sew. It is to prevent air leaks or reduce the length of hospital stay after surgery. Very good method. Including me, actually, under the endoscope. It's okay to do a sleeve anastomosis or a broken blood vessel and bleeding. In fact, sewing is the basic skill. Director Wang, this surgery. I think each blood vessel is clearly dissected. Sometimes I don't divide blood vessels so carefully now. Then I think the blood vessels. That is, we can recognize this fault plane very well. Start marking this vessel. Now sometimes I'm lazy. I think it's still necessary to be patient and do these things. Director Wang Ming, let me add here 1+2 resection. If A, B and C are all cut off or a +2B, we often meet. Your patient today is between U and C. What do you do in case this patient has a poorly developed interlobar fissure? They were underdeveloped. Just along the artery from the trunk, separate a little bit from above to below. Ultrasonic knife to open the back oblique crack a little bit. See if you can expose this C branch. I think if this interleaf fissure is underdeveloped, you go from the front to the back. Go all the way to the interleaf fissure and finally hit. Oh, I try my best. This will definitely save a lot of time. Your ob is broken. Then your bronchus breaks and that's fine. Then you can cut it here too. Then the interleaf fissure is here to cut off at the end. This way there will be no air leakage and the operation time will be short. I do a lot of 1+2. I do this if 1+2 does not develop well. So I just did it. In fact, we often encounter 1+2 in amputation. I think the frequency of 1+2 surgery is also relatively high. Okay, you can put the second one. This is the posterior basal segment outside the right lower lung. It is 9+10 of the lower right lung. It was supposed to be two-way. Just start from the oblique crack position. Ligate off the artery in this target segment first, and then the no waiting method. And then very quickly the plane will be revealed. But it turns out it's quite deep. This one came out late, and there's an 8 branch blocking it. If you continue to do this, it will easily damage this 8. I encountered it before, so I thought it was okay later. Or do you do one way? We're also trying to take the root of this dorsal segment. It's 6, which is a little separate from the tongue. Then this is to open up this front and rear oblique crack for the convenience of rotating this lower leaf. Because the door is to be opened with a closure. And that brings us to the bayonet technique. The bayonet technique was learned from Director Chen. The advantage of this closure device to open the door is that it is faster. Use these oval pliers or tongue pliers to clamp in. After the surface of the inlet vessel separates, after a tunnel is divided, then insert it with the gasket of the closure. Yes, now it's using small-headed oval pliers to separate the tunnel. Right lower lung is rotating 90 degrees counterclockwise. And he opened the door with a closure. After opening the door, the front and rear are actually already open. Now, the purpose of this string is to make a mark. The top of this line is 6 segments. That is, to avoid accidental injuries during dissection. What we are looking for. This 90-segment structure. All below this black line. This surface of the trunk vein. 1 by 1 to treat 9+10 severed internal veins. In fact, it is best not to break all the thick veins. After the severed vein is sometimes found to be severed too much. A small branch. You can be very sure. This one must have severed the internal vein, so cut it off. Just scald it with an electric hook a little further away. It's fine. A slightly thicker ligation is super broken with an ultrasonic knife. It is also very convenient. In fact, although there are many, it is also quite fast to deal with. And in some places, we do it by toning. So as the veins get farther and farther away, the door below is actually gradually opening. After the upper and lower doors are open, this target bronchus is revealed through the inferior pulmonary ligament approach. The location of the oblique crack is parted late. It is easily exposed through the lower pulmonary ligament approach. This one is the 10-segment B+C bronchus. And it's the bronchi in the same vein. Break them one by one. I'm sure it's the broken bronchus. After breaking it, I found that there is another one. Put this tenor again. It's a subsegmental bronchial rupture. This can avoid multiple breaks and mistakes. Of course, when digging out the bronchi, behind it is the accompanying artery. To avoid damaging this posterior artery, Of course, the oblique fissure has actually revealed that the lower pulmonary artery has dried. Even this damage can be quickly contained. Here is the method of ligation with thick silk thread. Cut after ligation. Then take out this tenor. And here we see it coming towards this target. Because the B6 bronchus is above the 6th vein. So this is definitely not B6, it's tenor. I was wrong. This is ninap of 9. Ninap and 10 work together. And branch along this one further along. Go along this vein and loosen it forward to find the artery. And here we are going to cut out this group 12 node. Then leave the distal end of the bronchus. This is arterial 10. Method of ligating with silk thread. In fact, it is still relatively flexible. This is the artery. Ninap, there is ninap in it. There is ninea in the back. In fact, it is shared with 8, so both ninap and 10 have been broken here. The arteries and bronchi. And then we have some intrasegmental veins here. Leave the far end. It's facing the far end. We break the intrasegmental vein. Director Wang, are the 3 students doing it by themselves now? Yes, use Mini X. And there's pure oxygen in the lungs. But there's still a 9-digit one here that hasn't broken yet. This is also the way to open the door. Break this along the current plane. It's actually rotated 180 degrees here. This compartment faces the hay. This is to facilitate the shooting of the closure device. After opening it here, I found that there are still some structures of ninea. Venous bronchi. This little artery is then dissected separately. After opening, these structures become easier to uncover and process. Especially after opening doors on both sides. This is equivalent to reducing dimensionality from 3 to 2. I think this is a very important idea for lung surgery. It's dimensionality reduction. Then the margin is sufficient. You see there's another lung left there between stages 6 and 8. If you go to the frontal interleaf fissure, you have to remove this piece. It was always like this when I started. It's all separated between the 8 dorsal segments and the basal segment. You see, he doesn't need to be separated here either. Usually 9 segments, 10 segments, or 90 segments are removed. We all like to walk under this. You see, this place just started burning with an electric knife. Then you see it's all sewn. After sewing, it is very simple to sew a few stitches. No air leaks. The bronchial stump here is not very reassuring. Just reinforce it with this intermittent stitch. However, there is no obvious air leakage here. After bulging like this, the two sides are actually pasted together. It's folded. For many postoperative. Once there was a live broadcast of surgery, I chose 10 live broadcasts. Do what you did that day, how. It took like 2 hours to get it right. Later, I saw that Director Wang did a very good job and was very skilled. And the structure is very clear. It reminds me of myself at that time. I wanted to do it and regret it later. How did I choose 10 segments for surgery live broadcast? Many of these skills were learned from Director Chen Qishuan. Director Chen, please tell me briefly about this bayonet method and the method of identifying the structure of the lung target. You briefly introduce. You are doing better than me now. It's just me sometimes. Just before I broke the door, I put the pliers. Because when the bronchi and blood vessels are all broken, after the break, I will be lazy. Just eat it in the intersectional plane. After eating it, knock out the cavity. It would also be dimensionality reduction. But there's a problem with this. Sometimes a small amount of bleeding, but the bleeding is manageable. Our leaks are often on the surface. Did you notice? It is the crack between the leaves, and air will leak if it is slightly divided. There is more air leakage than the middle one. And it's actually connected at this point on the surface. The deep is disconnected, so we are deep in many cases. Even if it is swept from the ultrasonic knife, there will be no air leakage. Yes. Air leaks in this place. This place needs to be sewn deep. You can see that it is not likely to leak. If this small glue is missed, the problem will be solved. Alright, timeline. I don't comment much either, because overall, the surgery went pretty well. What you said just now. Is there any trick to bayonet this tunnel? The trick with tunnels is to follow the plane between faults. Just make sure you don't touch the blood vessels. Your major blood vessels are broken. What are you afraid of? Just plug it in and knock it off. One more question. We used to have a deeper location. What about a wedge resection in this patient? After I locate it, I'm boiling in front of the positioning. Then eat it with this and beat it like this. I think this bayonet method is more practical. You know what I mean. It's just that this patient's position is deeper. If you do a routine resection, it will wrinkle very badly. What should I do? The positioning must be determined. Otherwise, I can't touch it. Position this place in front and I will bore it deeper. Then I use the gun. Because. Open it from the side. Dig the roots a little deeper and hit them again. What's in it? The lungs don't fold easily. It's better if the lungs are inflated. You should see what I mean. It's this very thick section. Burn him with an ultrasonic knife or an electric knife first. Then stuff it in with this. Poke the oval pliers with the small head in and divide them. Right. And then the closures open in layers. Right. Good, Director Chen. 2 more questions about this live stream. Is it all suitable for ligating the segmental bronchi with thick silk thread? Generally, how thick is the bronchus? It is safe to use ligation. Is it necessary to suture after a thicker bronchial ligation? For example, the anterior, apical, posterior part of the upper lobe. No problem, they all have thick silk thread ligation. As long as you tie it tightly, tie 4 or 5 knots. Then cut a little longer from this wire connector. Because it is 0.5 cm, so there will be no problem. You have a problem shooting. Some people use green spikes to shoot guns. After the green nail, you can't close it well. Then dorsal segmental bronchi. It will also be thicker. You can have a vasectomy. After ligation you can use proline wire. Or use this other wire. Absorbable line also works. It's okay to give it 2 stitches. Broken bronchus. I don't like to use thread. What's wrong with the line? The field of view also affects when I type in. In fact, why do we end hole? I introduce more. One mini likes vasectomy. It's not that I save. Saving is of course the same issue. Ligation is safer in many cases. The vision is better. Sometimes the gun comes out and breaks the blood vessel. The bronchi is mistaken and often touched. What you said won't. I think a broken bronchial ligation is safe. This far end of your ligature should be slightly longer. Want the bell mouth to come out. It's perfectly safe. You don't have a bell mouth, it slips off. In fact, the video of director Wang Ming in front, I think he added 2 lines. Because you are very rigorous. In fact, this one is enough. Another problem is how to identify the bronchi. Which section does this bronchus belong to? Do a treat reconstruction first. If it is difficult for you to distinguish, this broken bronchus must be able to distinguish it. I like how to tell the difference. Upper lobe, for example. I will break the blood vessel later. I will read all 3 paragraphs. Cut to the back end, free to the root. I am scissors to cut the root again. This is the best way. Is to show him the adjacent bronchi. The best to see. When you do 1 + 2 now. I want the front paragraph to be able to see it best. Take a look. Take a look. At least I can feel it. So look for this adjacent section of the bronchus. We have to start at the root. But the roots are hard because the anterior vessel hit here. The blood vessel is about to break, and the bronchus will be broken before looking for it. Oh, it can't be exposed before it breaks. Can't be exposed. Something like the dorsal tongue is better. We are doing a dissection now and we'll definitely do that. It's better to start doing these parts. Basal segment is a little harder. When identifying. For example, this is continuous. Just use pliers to clamp and bulge your lungs. See if this adjacent segment bulges. This method can. Sure, okay, this is one way. There are other ways. For example, if you are like Japan, you use the method of jet ventilation. But that's a tall order. The anesthesiologist is right under the bronchoscope. Put the target bronchus in the tube. Like a jet plane, that's the jet. After spraying it, this target segment will expand. It's too technical. It's not used that much either. But I think the blood lock is broken if you do it fast. I think it's pretty good to use silver. For younger patients, it is. Peng Xiong way is better to start first. Older people come slowly. So it would be better to have that fluorescence. Now thoracic surgery generally involves 2 types of surgery. Segmental excision will be more difficult. And cuff resection. Both surgeries are relatively more difficult in the future. This time due to time constraints. I hope Director Chen Qixuan and Teacher Chen Da come and connect with our experts. And some other tricks about the esophagus. I also learn from everyone. Okay. Does Mr. Chen Da have anything to add and summarize? Not really. No, actually. Director Chen also made a very systematic summary. Here we are now using scissors a little more. It's not just about separating duodenal lymph nodes or blood vessels. It's actually in the cut. It is the scissors that protect the retained trachea quite well. Because the ultrasonic knife will still have thermal damage, it was fine. But like Director Wang. For example, this one is a little broken. The bronchi are all naked. The ultrasonic knife damage. Late delayed leakage. I think it will still be somewhat relevant. At this time, if you use scissors, of course, skilled with ultrasonic knives. For a short time, I think it's okay. Scissors are a better choice. cut the scissors. You would have noticed the leak at the time. It doesn't have late onset damage. If you find it, you can sew it up. But I'm just worried that it didn't leak at the time. After going back, the small leak on the trachea will come out again. Or this one clamped with an ultrasonic knife. Some of the lung tissue was clamped, but it's been a long time. Some leaks occur after the eschar falls off. I think sometimes it still shows up clinically. Nothing else. The handmade video is really good. Surprised by this, because I have suffered myself. Do a time slot for a surgical demonstration, and it was really embarrassing and staged. Then go back and think about it for yourself. There was indeed a problem with the choice at that time. At that time, my technology was not good enough for surgery. Not to the extent that you can get it smoothly. Today, I saw that Director Wang did this surgery so skillfully. I think I've learned a lot again. I also learned a lot from my two teachers. Ho, thank you very much for the wonderful sharing of Director Chen Qixuan and Director Chen De. Welcome to the bullet comment section and the expert group of External Thoracic Surgery Network held a lively discussion. Thank you again for watching and asking questions. The 12th issue of the next live broadcast of Big Coffee Connection, tentatively scheduled for 7:30 this Thursday night. The keynote speaker is Director Fong Women of Fujian Cancer Hospital. Welcome to Interact Online. See you next time. Alright, bye-bye.